It is nice to see a lot of new faces here, a lot of familiar ones, but a lot of nice ones. My talk today is about alternatives to Obamacare. Very, very important. As Dr. Antun mentioned, I am a registered employee benefit consultant. I work a lot on self-funded plans. I consult for politicians and governments, state and federal, on healthcare provisions. I spend a lot of my time lately specifically looking for solutions to get out of Obamacare. I'm not talking about repeal because, I mean, that's obvious we have to repeal it, but while we have it, what can we do to get out? Thanks. And I testified in front of the state of Florida 2 weeks ago. They're looking for alternatives, free market alternatives for their 173,000 state employees. And what I started with is something that they found quite eye-opening. When we hear about healthcare reform, and we're going to reform healthcare and all that stuff, nobody has ever defined what is healthcare. What's the product? For those of us out here today that are old enough to have turned on a high beam with their left foot, you'll remember when the product was medical treatment. When Marcus Welby was the doctor and you went there, and the product you purchased was a service. It was a medical service. Today the product is healthcare. And what does that really mean, healthcare? It's a financial instrument. Health insurance, prepaid healthcare, whatever you want to call it. But that's what they're selling. Okay, it's a financial instrument. Now, with the medical loss ratio under Obamacare, the insurance companies are required to spend 80 to 85% of your premium on medical care, which means the piece they're selling is only 15 to 20% of the pie. So it's like the tail wagging the dog. It's trying to push a piece of spaghetti. But the thing is, and Mark Schiller told me this morning, he says, for a doctor, you can't leverage your time. Your time is limited to 24 hours in a day. So that's the limit of your service. However, a financial instrument can be leveraged. Now, who are the people that have figured out in the past that you can make a lot more money off of a financial instrument? Well, there's Goldman Sachs, Lehman Brothers, Bernie Madoff, and Blue Cross. Okay? So therein lies the fundamental problem, is that it's been disconnected from what the product needs to be. Really briefly, because there's a lot of new faces out here, what is Medibid? Medibid is a company that I co-founded and we opened in 2010. It's basically a virtual online marketplace, sometimes called the Travelocity of Healthcare, where doctors and hospitals can put their profile, the services they provide, where their education is, training experience, and then patients, and they generally fall into three categories: uninsured, those with a high deductible, and those with a self-funded employer health plan, not a Blue Cross health plan, self-funded, can make a medical request. They can say, I want a knee replacement, colonoscopy, need to see a family doctor, whatever it is. That request is sent out by email to everybody who is registered on Medibid, and the doctors create a custom bid, a custom quote, kind of like a contractor would when he's renovating your kitchen, and sends it back. So it turns the product back into medical care. Rather than being paid by a CPT code and being a widget or a sub of the financial instrument, this is centered on the product. Now, when we're talking about alternatives to Obamacare, first we have to talk about some of the fines and penalties. Now, I'm going to go over this really quick. Most of you probably have a rough idea of what this is. The individual mandate, which kicked in this year, is 1% of your adjusted gross income, or $95, whichever is greater. And this year, I think 68% of the time it's going to be the 1%. Next year it's going to be 2%, or $495. The year after, 2.5%, or $695. That's the individual penalty for not having a compliant plan. The next two penalties or fines have been delayed for a year. However, they are scheduled to start in 2015. They are the employer mandate, and there's two different categories. There's the sledgehammer penalty, which is what we call it, which is $2,000 per employee per year, with an exemption for the first 30. And there's the tackhammer penalty, which is $3,000 per employee, which is levied if you do offer a plan, but it doesn't meet either minimum value or affordability. We'll get into that in a future slide. The third penalty, which is a new one, is discrimination under Section 105HB. There's always been a Section 105H, which is the discrimination clause. However, it's now being applied to fully insured benefits. What this basically means is if a highly compensated employee of a company has better benefits or a greater employer contribution than a lower paid worker, then the employer has to pay $100 per day per employee discriminated against. I had a radiology group, not a big one, 200 people. They faced potential penalties of $4 million a year from this one alone because they contribute 100% for the physicians and 80% for staff. So that was $4 million a year. The fines, the employer fines apply to applicable large employers, that's what they're called, and those are employers with 50 or more FTEs. FTE means full-time equivalent, doesn't mean full-time employee. Full-time equivalent means 30 hours of payroll. So if you have 3 people working 10 hours a week, that's 1 FTE. The measurement period is 2013, and now that it's been put off 2014, the fines kick in 2015, and they are applied to every employee after the first 30. So if you have 31 full-time employees, then you're fined for 1. If you have 100, then you're fined for 70 of them. Now, they also use the control group rules. And this has hit a lot of people that wouldn't normally be hit. For example, if some of you own part of a surgery center and there are 18 people there and you've got 12 people in your own office, suddenly there's 30. And if you have a few shares in something else, they all add up together. So don't make the mistake of thinking, well, I've only got 20% interest in there, so that doesn't really count. They add it all up together. The sledgehammer fine, the interesting thing to add to what I said is it is levied if the plan does not offer minimum essential coverage. Very important. If you have a self-funded plan, it's governed by ERISA federally. Minimum essential coverage is defined simply as unlimited preventive care with no cost sharing. If you have a fully insured plan, it's governed by the State Department of Insurance, and it has to offer essential health benefits. Essential health benefits are determined state by state. Each state decides what it has to offer. Roughly, there are about 10 or 11 items, such as emergency room, mental health, brand name drugs, inpatient surgery, outpatient surgery, doctor's visit, imaging, et cetera. The things that are considered, a normal health plan type of coverage, but each state can add more or less. So some of the really wacky states could add all kinds of stuff. Mythbusters. Now, I hear this from a lot of people. They say, well, if I just find a plan that meets all these standards and I offer it and nobody takes it, I can say I offered it. Okay? The problem with that is the following. If you get a quote, let's say from Blue Cross or United Healthcare, you offer to your people, nobody takes it, a policy is never issued. Therefore, all you've done is offered a quote because the product isn't issued. If 2 people take it and 48 don't, and they still issue it because they don't have to because of participation, but assuming that they do issue it, then yes, you have met the requirements. However, if you just offer it and nobody takes it, it's not issued. So that's important to know. The tack hammer penalty that we spoke about, that's $3,000. Although it's a greater amount, there's less exposure because this is only on the people that actually go to the ObamaCare exchange and actually receive a subsidy. In order to receive a subsidy, they have to have gross income at or lower than 400% of federal poverty line. Family income is taken into account. So you might have a worker that only makes $20,000 a year, but that worker might have a spouse that makes $60,000, which might disqualify them. Affordability minimum value. Affordability means that your lowest paid worker can contribute no more than 9.5% of his or her income. So if somebody works 30 hours a week at minimum wage, they're earning about $1,000 a month, so their contribution can be no more than $95. That's the affordability. Minimum value is an actuarial formula that is calculated to determine 60% of what's offered under a normal plan. Deductibles, copays, and whatnot are taken into account on that formula. Now, what are the kinds of things that make health plans costly? PPO networks. We have huge variation, 1,000%. It's mostly the facility charges. It's mostly the facility charges, not a huge variation in professional fees. There is some, but not as much. The hidden fees that are embedded into most PPO contracts, the network fees, because what happens in a nutshell is the facility will bill charge master, which could be 600% of Medicare. It's repriced roughly in half for the discount, down to 300, but then they usually will pay only about 125% of Medicare. So there's a big gap between the 300 and the 125. Those are the hidden fees. The access fees, which is kind of part of that, and of course the carriers they want to increase healthcare costs. Some people actually think that they want to reduce it. Nothing could be further from the truth. With 15 to 20% medical overhead allowed due to the medical loss ratio, if you buy a life insurance policy, car insurance, house insurance, disability, the insurance company has your money for decades, 30, 40, 50 years. Even if they're only making 2-3%, they make it for decades. But with health insurance, they've got your money, well, they have to spend 85% of it by December 31st. So they have to spend 100% roughly middle of February. They don't have the time to make interest earnings in that short a period. So the only way they can make money is on margin. So if you go for an MRI instead of an X-ray, they make more money. So they want to increase costs. Oh, and of course the Medicrats. This, of all people, this is a Himmelstein slide, but I used it anyway. It shows that in 1970, if a town had 10 doctors and 25 medical bureaucrats, that same town by the year 2009, the doctors had increased from 25 to 75, but the bureaucrats had increased from 25 to 750. Okay, so there's huge waste. I was talking yesterday to a medical school in Louisville, and I explained to them that with the medical loss ratio, first of all, you lose about 15 to 20% of your dollar. When you pay Blue Cross $1, only 80 of it goes to medical care. Doctors' offices, as you know, have huge overhead. One of my clients had 87% overhead. Family practice clinic, 2 doctors, 1 full-time, 1 part-time PA, 12.9% of their revenue went to the physicians. So 87% overhead. So you're getting, and that's kind of an extreme, but we know it's always high. They ended up declaring bankruptcy. However, if you're only getting 13% of 80%, I mean, you're getting a dime on the dollar. That's what's going to medical care because of all these Medicrats. Let's talk about the cliff deductible. Most health plans have an annual cliff deductible, but they have monthly premium. Most Americans work on a monthly budget. They pay their rent monthly, their premium monthly, their car insurance, their house insurance, but they have this annual deductible. Why? It doesn't make sense. When you look at the 4 kinds of claims, medical claims, the first one is catastrophic. And when you talk to an employer, they keep increasing their deductible. And if you ask them why, they say it's to reduce costs. So your catastrophic claims, heart attack, cancer, stroke, car accident, you're not going to change those with a higher deductible. Next one is chronic, diabetes, hypertension, obesity. Those people they're unhealthy people. They're going to go through their deductible in 2 or 3 months. You're not really going to have a huge effect with a higher deductible. The third one is frivolous claims. They usually occur in November and December, used up their deductible, and they just go to town. I mean, you probably see higher volume, many of you, in the last few months. And the fourth kind is early stage inexpensive claims. Like my mole is changing colors, I've got headaches, I've got chest pains. Most people, if that happens in November and they haven't used their deductible, they'll say, you know what, I'm just going to wait until January. I got a new deductible. Why waste my deductible? By that time, it could be a stage 3 claim. So annual deductibles drive up costs like crazy. The mainstream solutions. So what are United Healthcare and Blue Cross and the Mercers and the mainstreams, what are they proposing? I don't see anything creative. I don't see anything innovative. I don't see anything that's a whole lot different than the status quo. We have so much business uncertainty, especially in the last 5 years, that businesses are clinging to the known. And I call it hugging the cactus, because they're holding on to a solution that they know doesn't work, but it's because of the uncertainty. We're coming to the meat of the presentation now. The MEC strategy is something we've developed. Now, you remember I said unlimited preventive care is the minimum essential coverage that must be provided by a self-funded health plan, okay? What we've done is we've eliminated the PPO reimbursement because PPOs are wasteful. We've talked about that. So we have a reimbursement schedule. We don't have an indemnity plan because those are very costly, because basically anything up to charge master must be reimbursed. So we'll usually take a factor of Medicare. For example, Medicare plus 30%, Medicare plus 50, Medicare plus 100, and we offer that to the employer. Here's your reimbursement schedule. This is what it'll pay. There's no network. You go to anybody and you say, here's what it's paying. Will you accept that? Yes or no? You self-fund the benefits, and in some cases, if it's a major medical plan, you're going to want some stop-loss insurance. Now, I agree with Dr. Huntoon about insurance companies. I do 100%. Self-funded plans, the stop-loss falls into a different category. I mean, that's real insurance, just like house insurance, car insurance is, not this prepaid health care. It's not managed care. Monthly deductibles, we talked about the annual cliff deductible, changing that $5,000 annual to $500 monthly reduces cost by about 21%. So we change the paradigm here. And offering a minimum essential coverage plan, a MEC plan, with the opportunity to buy up to a minimum value plan. And as long as the portion of buy up is within that 9.5% to keep it affordable, you're out of both mandates. Now let's talk about individual exemptions. One of the individual exemptions that's built into Obamacare is Section 5000A, which is healthcare sharing ministries. There are 5 in the US, however, only 3 are qualified. And they're qualified because they were established prior to December 31st, 1999. And they are Samaritan Ministries, Medishare, and Dr. Eck, which the Christian Health Ministries, is that the third? Okay. They are faith-based health-caring ministries. They each have a slightly different model. Samaritan Ministries is the largest of them. What Samaritan Ministries does is there's 2 kinds of medical expenses, shared and unshared. The unshared are expenses such as preventive care, colonoscopy without an indication, an MRI without an indication, an annual physical, glasses, dental. Those are unshared. And anything under $300 is a non-shareable. The shareable ones are, broken leg, knee replacement, cabbage, heart attack. The kinds of things you really need help with. Okay, those are shareable. And then they are shared among the members, the members who have voluntarily joined. Now, anybody that participates in one of these is exempt from the individual mandate, which we spoke about, which is 1% this year, 2% next year, 2.5% of gross income the year after. However, there's a problem in that the employer may still be subject to the employer mandate. I'll use Samaritan Industries, Samaritan Ministries as an example. They have 91 employees. All of their employees are members of the ministry and they're sharing costs. However, since the employer is 91, they're still subject to the employer mandate. On top of it, HRAs have been outlawed, standalone HRAs have been outlawed as of this year. So you can no longer have a health reimbursement account, which is tax advantageous. So we developed a strategy for Samaritan Ministries, which is a consumer MEC. Consumer MEC has, this particular one has a 130% reimbursement schedule. There's no networks involved, so there's no network access fees, no waste. Here's what it reimburses. And if the physician charges 150% of Medicare, then the patient pays the extra 20, no big deal. So if they wanted something where the Medicare rate's $1,000 and the physician says, I want $1,500, $1,300's covered, employee pays the rest. It's fully self-insured, there's no stop loss, so there's no insurance profit, there's no waste. And if the claims fund is not used, it stays in the trust account of the employer. There is a deductible of $3,000 for single coverage and $6,000 for family. Now, a lot of people ask me why, that's crazy. Why would you have a deductible for doctor's office visits? Here's why. That allows you to open a health savings account. The simple fact that you have a deductible that's more than $1,250, and in this case it's $3,000, allows you to open a health savings account. And the contributions to a health savings are about 3,000 family, 3,000 single, 6,000 family. So now you can put money into your health savings account to pay for routine things. The plan exempts the employer from the sledgehammer penalty, however, not the tack hammer, because it doesn't meet minimum value. However, if you have an employee group that participates in a Samaritan Ministries, they're exempt anyway. So the likelihood of them going to the exchange and getting a subsidized plan is very, very low. So the employees can participate in the Samaritan Ministries or Medishare type of program. And any of the large shareable expenses under Samaritan, they're covered up to $250,000. If you opt up to the Save to Share program, which is a little bit extra, there's an unlimited cap. So that, in essence, acts kind of like the stop loss for the catastrophic. So it gets the employer out of the sledgehammer. The employees are already out that are participating, and you have an unlimited for the shareable expenses. So self-funded plans, also known as ASO plans, have a lot of advantages over the self-funded, the fully insured plans. We talked about that a little bit earlier. The biggest one is that they only have to offer minimum essential coverage, not the essential health benefits, which is a lot less. Here it kind of outlines the difference. Fully insured has to offer the essential health benefits. Both of them have a cap. However, the self-insured plans can have any payment schedule. They can have composite rates. They can be fully underwritten, and you don't have to have the managed care component like you usually do with a fully insured plan, unless you get really expensive indemnity plan. The way that the self-funded plan integrates with Medibid is because they're given this schedule, so they're told, okay, you're on a plan that's Medicare plus 30, Medicare plus 100. So the employee logs on and they see what their coverage is. They say, I need a colonoscopy. How much is my benefit? Let's say it's $1,300. They send out a bid. When the bids come back, they know, okay, the $1,500 one I'm going to have to contribute to, the $1,300 one I'm fine. So you have transparency, you have competition. Physicians are allowed to set their own rates. I wanted to close by showing you this video here. It's just a 3-minute video. Do I still have 3 minutes? Yeah, I do.
I needed a full hip replacement. I was in excruciating pain. I hadn't gotten a full night's sleep in over a year and a half. Finally, my surgery was scheduled for Tuesday, March the 19th, 2013. The Friday before my Tuesday surgery date, I received a phone call from the hospital in Houston. The man on the phone told me that there was a problem with my insurance and that my insurance wasn't going to cover the cost of the hospital fees. Now, I was driving when I received that phone call and I had to pull over because it felt as if my heart stopped right then and there. He told me that the hospital fees alone were going to cost over $100,000. I tell you what, at that point, you talk about pain. I was feeling more pain than ever after hearing that. Now fast forward 3 days and still feeling cheated, I was brainstorming and I Googled cash surgeries. Amazingly, thank goodness to Google, I was led to a website called Medibid. The following day, I received my first bid for my surgery from India. A package deal for the entire surgery and hospital stay for $7,000. A couple days later, I received 2 bids for my surgery, both from the Houston area, and both in the neighborhood of $15,000. Now at that point, I couldn't wipe the smile off my face even if I wanted to. And 2 days later, I received a bid from Dr. Adam Harris in San Antonio for $21,000. And Dr. Harris said in his bid that there would be other bids lower than his, which there were. But he also stated that he charges a reasonable fee for high quality service. I evaluated all the information that Dr. Harris provided on the website. And then I did my own homework. Although Dr. Harris was $6,000 higher than the other bids from Houston, because of my research that I did on my own, I had a great feeling about his track record. I'll never forget that Sunday afternoon when I received a phone call, and it was Dr. Harris calling to introduce himself to me and to check on me. And you got to understand, to that point, I had been disappointed and depressed and hung out to dry by my big insurance company. And here, this doctor was calling me on a Sunday afternoon to check on me. I was overwhelmed. And I'll tell you what, after our conversation that day, I knew that Dr. Harris was my guy.
Okay, thank you.